5, 4, 3, 2, 1. We are live now.
Good morning, everyone. Welcome to Ortho Kids Fellows Teaching Session. And in today morning session, we have a very interesting talk. What is not juvenile idiopathic arthritis? We see lots of children with joint swelling and pain. And many a times, we are confused as whether it is rheumatoid arthritis or some other ailment. Dr. Puja Srivastava is an eminent rheumatologist from Ahmedabad. Her training, she has a graduate from AIMS Delhi, and she has been associated with us for last 10 years now, and we have been very fortunate to have her in our team. She has helped us in many patients and demystifying the diagnosis. So welcome, Dr. Puja, and thanks for your time.
Thank you, sir.
You can share your screen and you can start your presentation.
So, JIA, juvenile idiopathic arthritis, it's a common term for all sorts of arthritis in children. So it's the umbrella term for all kind of unexplained arthritis in children. It's the most common rheumatic disease in pediatric population, and it's the commonest cause of chronic arthritis in children. So overall, the prevalence is around 1 in 1,000. So every week, probably we are going to see 2, 3, 4 children with JIA for all the people who are looking after joint issues in children. It affects females more than males. This happens in all autoimmune diseases. And in general, for JIAs, we see 2 peaks. One is in the first 5 years of life, first 1 to 3 years. There's generally oligoarticular, 1 or 2 joints are swollen. And then the second peak is in the prepubertal age groups, where we see more of polyarticular variants. But in between, we see other variants also, and there can be overlap. Over years, the classifications has been changing, but overall, JIA is a systemic disease. To discuss what is not JIA, we need to understand a little bit about what is JIA. So, JIA is a systemic disease. We generally compare all these inflammatory arthritis with diabetes and hypertension. Those are diseases which routine, even everybody understands that requires long-term treatment. And it's not only the thing which we are seeing, not only the joint, it does affect other organs of the body. Like apart from the joints, it affects the periarticular structures like enthesis. It can be associated with skin rashes, some pleuritis, pericarditis, mild ascites. It can cause fevers. It can cause anemia. Sometimes long-standing untreated arthritis can lead to renal dysfunction because of secondary amyloidosis. And it can have, like systemic JIA, sometimes can lead to press on those kind of manifestations because of uncontrolled disease or secondary complications like macrophage activation syndrome. So normally there is joint inflammation. There is good going systemic inflammation. In some forms, there can be some antibodies, and that leads to a systemic disease. It's not just the joints. So how do we diagnose JIA? We know it's a chronic inflammatory arthritis. Here, the arthritis has to be of unknown origin. It should start before 16 years of age. It should persist for more than 6 weeks. And other known differentials must be excluded. So it's a very heterogeneous group. And for diagnosis, we need all 4 of them. Unknown origin, less than 16 weeks, duration more than 6 weeks, and other known DDD. Differential diagnosis has to be excluded. And if we say, like, among the 4 criterias, which one is the most important criteria? So it would be the diagnosis, a differential diagnosis that has to be excluded. If we have excluded other differential diagnosis, only then we can diagnose a JIA. So if we see the list of differential diagnosis, it's huge. It can vary from non-inflammatory or degenerative conditions like Perthes or slipped capital femoral epiphysis presenting as hip pain. It could be post-infectious arthritis. Many forms of reactive arthritis could be post-trauma, could be because of hematological diseases, could be because of metabolic diseases like rickets and other storage or endocrine disorders. There could be idiopathic like sympathetic reflex dystrophy, fibromyalgia, or some idiopathic osteolysis of the bone. There could be neoplastic reasons. There could be primary infections, and then there could be multiple systemic diseases like connective tissue disease, vasculitis, and others which can lead to arthritis. So once we have excluded all those, only then, and still there is an unexplained chronic arthritis, then we call it as JIA. And that unexplained one is the most common. So how do lab tests? Are there any lab tests which tells us that yes, this is positive and so this is JIA? Overall, there are no tests which can diagnose JIA. All these tests, acute phase reactants, ESR, CRP, ferritin, complete blood count, liver functions, renal functions, most of these reports are a must to exclude the differential diagnosis. When we have this unexplained chronic arthritis, some reports do help us to make the diagnosis, such as rheumatoid factor, anti-CCP antibodies, ANAs, HLA-B27, sometimes the whole genome sequencing. And if many a times when these are also negative, the imaging modalities like X-ray, which is showing joint erosion or joint space narrowing, ultrasound or MRI, which shows synovitis or bone marrow edemas, they also help in diagnosis. But none of them are diagnostic. Their presence, absence, or abnormalities do not definitely indicate the presence of JIA. So diagnosis of JIA is clinical. It's a clinical diagnosis. Now, the classification. At present, ILR classification is still being followed. There are a lot of modifications and research going on because even this classification is not very sacrosanct. There are a lot of overlaps between different groups of JIAs described in this ILR classification, but generally it describes arthritis based on the number of joints which were involved in first 6 months of disease. So in first 6 months of disease, if it is less than 4 joints, 1 to 4 joints, then it is called oligoarticular JIA. If to begin with or within first 6 months, 4 or more, that means 5 or more joints are involved, then it is polyarticular JIA. In between the oligo and polyarticular, there can be more of oligoarticular with asymmetric and sometimes the spine involvement, that is enthesitis related arthritis, where there is a lot of back pain and hip involvement and tarsal joint involvement, affects more in boys. And if that spectrum has psoriasis in it, then it becomes a psoriatic arthritis. And then there is a systemic variant which generally presents with predominant fever and systemic inflammation and can have joint pains. So oligoarticular is the variant which is most commonly reported across the globe. It generally affects the younger lot, 1 to 3-year-old female child more, and it is associated around 50-60% of them have ANA positive. And apart, they generally present with 1 or 2 knee involvement, knee monoarthritis. It can be associated with uveitis, more so if their ANAs are positive. And this is the one where sometimes we need to do joint aspirate to exclude infections, TB, and it is probably very much misdiagnosed and confused with TB. Many of these children who come with one knee arthritis are treated with anti-tubercular treatment or a lot of other alternative treatments before they actually receive disease-modifying drugs. But in India, our data says that we have ERA as the most prevalent subset. the data from PGI Chandigarh, SGPGI all shows that in India, probably ERA is the most common subset. ERA is actually enthesitis related arthritis, the second column. So this generally occurs in male child. It is 36% most common in India. It is more common in males, generally starts around 6 to 7 years of age, presents with knee or ankle arthritis, sometimes hip arthritis. 25% of them can have uveitis. Around 70% of them are HLA-B27 positive. A good proportion of them may have a positive family history. Somebody, mother, other siblings, father or uncle, or may have chronic back pain who would not be diagnosed. Some of them may have psoriasis or psoriatic arthritis history. And many a times here, the enthesitis is more common than a good going prominent arthritis. So this really needs to be picked up. This one is the most misdiagnosed one among adults also. Now coming to polyarticular, here probably the diagnosis of JIA is easy because they present with good going pain and swelling in small joints of hand and feet. Again, more common in females. Around 20% of them can be ANA positive. The RF positive polyarthritis is generally more destructive. It causes more joint damage, and it's the pediatric counterpart of adult rheumatoid arthritis. The RF negative polyarticular JIA, it has a peculiar kind of arthritis where you see more of tenderness and joint deformities, but somehow that much synovitis is not seen. Many a times joint aspiration also gives dry tap, but it also causes a lot of deformities. Then systemic JIAs, there we have a tendency of emergency to diagnose it early and treat, because a good proportion of them can develop macrophage activation syndrome and secondary amyloidosis. But if treated in time, diagnosed and treated in time, all of them do good. So in general, we saw the list of different, we have understood what is JIA. If there are some doubts on this, we can still discuss in between also. Otherwise, now little bit about JIA.
So Dr. Puja, before we go to mimics, the few questions.
Yeah.
So let me start. Are all ANA positives are confirmatory of JIA? You probably said no, but
No. None of the tests are confirmatory for JIA, because ANA positive could be connective tissue disease also. It could be lupus, it could be juvenile dermatomyositis, it could be systemic sclerosis.
So can I say, I mean, if there is a clinical scenario where you think it is JIA and it is ANA positive,
yes,
can it be taken as a confirmatory diagnosis of JIA?
No, sir. JIA doesn't have any confirmatory test. It's a
In the absence, then why do we get a ANA done?
because
my people here also get a ANA done, and then if
So
the
this-
ANA is negative, they will send back, okay, this is not JIA.
Okay, no, it's not like that, sir. So ANA positive in JIA, it signifies a specific term like ANA positive in oligoarticular JIA predicts the development of uveitis. And these are very small kids, 1 to 3 years old kids who are even not going to school. They won't complain of uveitis. They won't complain. They are not yet that much developed and say that I am not able to see things. And this kind of uveitis in oligoarticular JIA is actually a white eye uveitis. You will not see the eye becoming red. It's mild photophobia, mild pain, but those small children don't complain. So it has to be screened. So in oligoarticular JIA, if ANA is positive, you will screen these children every 3 months till they are at least 6 years of age, and after that also every 6 months for development of asymptomatic uveitis, because that can cause vision loss. Now there can be another scenario also. ANA is positive and that is treated like oligo JIA. Later, 6 months down the line, the same child develops a ascites or a pleural effusion or some skin rashes. So probably it has now progressed towards connective tissue disease. So although it's not very much recommended, if ANA is positive, you go ahead with doing ANA profile and complements and all those tests. I have come across 2, 3, 4 patients where we initially diagnosed them as oligo-JIA and later on they evolved into connective tissue disease as full-blown nephritis and all those. So if ANA is positive and the family is affording, we can go ahead and do a ANA profile. The kind of ANA which is positive in oligoarticular JIA is generally the profile will be negative, or at most some histone will be positive in very low titers. But the ANA positive oligo-JIAs must be sent to a pediatric ophthalmologist till the first 4 years of disease or till the child is 6 or 7 years of age, even if they are not having any ocular symptoms, just to screen for asymptomatic uveitis. That way we can save a lot of vision.
So, Pooja ji, if I just rephrase the question,
Yeah.
if a patient comes to us with joint swelling,
Yes.
more than 6 weeks history,
Mm.
we got ANA, ANA is positive, then we should refer it to ophthalmologist. At the same time, if you have rheumatologist, to
Yes,
make
yes.
sure that there is now no other reasons of positive ANA, right?
A rheumatologist can start the DMARD. Even the rheumatologist will send to the ophthalmologist for a UVI examination.
So that's a great thing. Now, second thing is, now we, as you say, we have two spectrums of disease, adolescents, and sometimes we, to finish the list, we send ANA as well as HLA B27 and, SGPTs and all those stuff to finish the investigation list. Even younger children, should we restrict ourselves to ANA in younger children and HLA B27 in adolescents with some
Yes. Yes, in the very small children, 1 to 3 years, probably doing ANA, and the test which has to be done is complete blood count, kidney functions, liver functions, acute phase reactants, chest X-ray. This has to be done in all patients.
Okay.
Then when we are suspecting oligo-JIA, then ANA has to be done because that has prognostic significance and that could save vision for those children. And
Dr. Puja, yeah, can I?
yes, yes, sir.
So, regarding this is regarding HLA B27. Correct me if I'm wrong. As I understand that HLA B27 is primarily associated with spondyloarthropathies,
Yes.
right?
Yes, sir.
But any person who has a HLA B27 does not necessarily fit into a spondyloarthropathy.
Agree, sir. Yes.
Right. So what is the purpose of getting HLA B27 done? I mean, a lot of my people also get it done.
Yeah.
So I'm really not aware of the significance of HLA B27.
Yeah. So, sir, around 8 to 10% of general population is HLA B27 positive, who are healthy, who are not having any disease. And the prevalence of HLA B27 among spondyloarthritis is around 60 to 70%. So where we have a very established diagnosis of spondyloarthritis, like bilateral sacroiliitis or a unilateral sacroiliitis with enthesitis and oligoarthritis, there we don't need HLA B27 to make a diagnosis. But for a borderline case, like a child presents with chronic hip arthritis of 5 months duration and has raised acute phase reactants, there is a family history of some paternal uncle having chronic backache for 10 years, but that person is not available for examination. And at present, the child doesn't have sacroiliitis and no other features. So their presence of HLA B27 will help us to fit the child in the criteria of ERA. So the role of HLA B27 is only to establish the diagnosis in borderline cases where we have a very established clinical diagnosis. We may avoid doing HLA B27 because that doesn't have that doesn't guide the treatment actually.
Yeah, that is what precisely my next question was, that even if you get a HLA B27 and it comes positive or it comes negative,
Yes.
does it alter your treatment strategy?
No, it doesn't alter the treatment strategy. But like the seropositive ones or these positive ones are generally said to have a more aggressive kind of disease. But it's not always uh, hand to hand. Like if it's positive, it will be more aggressive. If it is negative, it will be less aggressive. HLA-B27 accounts for around 30 to 40% of genetic pathogenesis of spondyloarthritis. There are a lot many other genes, which I think 3, 4 we know more, and lot many are still under investigation. So still around 60-70% of the genetic load of HLA-B27 we still don't understand of the spondyloarthritis disease is still under investigation. We still don't understand those in detail.
The key is, although JIA is a clinical diagnosis, we are not getting patients with typical history, in most of the time they are partly treated, or they do not have a typical morning stiffness, or they are not smart enough to explain that we feel stiff, and that's why we need to have this supportive tests. And I
Some
know that there are many centers where they don't have rheumatologists, so they have to, if their supportive tests are positive, they can, guide them for
So for
patients.
a scenario like a child of around 8 years age has come to us with a knee swelling and occasionally has back pain also, or may not have it, and he has been started on ATT, anti-tubercular therapy, for 3 months now. He's in between, in the middle of ATT, and he has not had much response to AKT. His knee swelling is the same. The child doesn't look toxic, but the knee arthritis is there, has developed a lot of quadriceps atrophy. Still, the acute phase reactants are elevated. Now, 8-year-old male child in India, we would think that mostly it is spondyloarthritis. That is the most common variant of JIA that we see in India. So there, if a HLA-B27 is positive, that would help us or give us little bit more confidence. We'll do a synovial fluid culture test, a TB workup. If all those are negative and HLA-B27 is positive, we will be more confident in stopping the AKT and starting uh, him on DMARDs. Or in our country, mostly we don't stop AKT. We would continue we'll complete the 6-month treatment, and simultaneously, because the intensive phase is gone, we'll start the child on DMARDs also. So
Right.
that in great borderline
Puja,
cases, it helps.
can I? Now, the two things regarding anti-tubercular treatment. One is that the current recommendations are
For the
current
joints,
government
I
of
know
India
it's
that you don't start anti-tubercular treatment without either a tissue diagnosis or with a CB-NAT positive
agree, sir.
in skeletal
Yes,
skeletal.
yes, yes. But most
Except
of the
perhaps for
time,
the spine where MRI is taken as one of the gold standards for
it's not,
starting
we
on
will
that.
not start, sir. But
Yeah,
if
it
the
has
child
But there are
already been.
people who
already
start.
been taken.
So
Now,
this is just for the residents actually.
Right,
That's what I
right, right,
was. Yeah,
right.
great.
now another question is, will be very quick question and quick answers because the main part is still remaining.
Yeah.
What are the common presenting symptoms in enthesitis spectrum?
Okay. So enthesitis generally presents with lower limb predominant oligoarthritis. So the joints involved will predominantly be lower limb joints, a knee joint, hip, ankle joint, tarsal joints. They can have hip pain. Sometimes the enthesis is the most common, like they'll have strong, like very severe tenderness on anterior superior iliac spine, patellar insertion site of patellar tendon, quadriceps tendon, tendoachilles, plantar fasciitis, and hip arthritis, knee arthritis, and tarsal and ankle. So these will be more predominant as compared to upper limb joints. Although ERA, the some variants can be really like, it can mimic polyarticular, and sometimes it can cause fever and lot of inflammation, but that's a small chunk.
Right. Now, another question, is it possible to differentiate the types based on knee aspirate?
No,
Answer
no,
is no. Yeah.
no.
If ANA is negative uh, in children, there is no need to screen for uveitis. or still we need to
So
screen?
oligoarticular variant, we would still advise to screen them for uveitis, because the way ANAs are done in our country is very, matlab, for some places it's very good. In the ANA negative ones, especially in arthritis, which is beginning in children less than 4 years of age, we would still recommend it to screen them for a year or two. In ANA negative ones, we can be little less aggressive because there the chances of developing uveitis is less. But first 2 years of disease or till the child is 6 years of age, it will be good to, if they see
So
ophthalmologist.
ANA negative, but clinically
Oligo JIA.
oligo JIA, infrequent ophthalmic reference should be done, if not
Yes.
at 3 months. Yeah.
And ANA positive ones should be at least 3 to 6 months, at least till the child is 6 years of age.
Perfect. Let's move on to the main talk of today.
So normally the list of mimics is huge, but we can list them as the ones which present predominantly with arthritis, the ones which present with arthritis with some bit of systemic or other organ manifestations, and arthritis mimics which are totally non-inflammatory. So those with persistent arthritis, this was a child I saw 4 days back, came with a 5-year-old girl child, 2-year history of joint pain, looking sick. I took their permission to share the picture. So not gaining weight, irritable, has swelling of all small joints of hand, feet, mild pedal edema, swelling of elbow, swelling of knee joints, and she has developed ulcer on one of the elbows. This is ulcer. So one elbow has this kind of rash and the other has developed this ulcer, has intermittent low grade fever and is irritable. So what do we make here? Does it look like a polyarticular thing? Young child, 5 year, with all polyarthritis. She weighed only 10 kgs at 5 years of age.
So I see a generalized kind of edema. So the nutrition-wise patient looks maybe hypoproteinemia is there.
Yeah.
That's one. When we see these ulcers, then we should rule out some kind of neurological involvement and the sensory issues.
Right.
But I
Right.
cannot think of any differential having
It
joint
could be
pain,
even osteomyelitis, like patients with
multifocal.
yes. And the rashes now, what we are seeing here, if we little bit, this was the X-ray of this elbow. Initially, we were thinking of osteomyelitis, probably one of the, because it's chronically inflamed elbow, probably it has become secondarily infected because she was taking some over-the-counter treatment at her village.
So we can, if I read this X-ray, there is some swelling in the joint synovitis. We can see them blackening, and there is some lytic small area in the radial neck. So an MRI would be helpful to rule out if there is
And
really a joint
this
infection.
thing, this white structure here,
Yeah. So this can be an
could it be a calcium deposit or something?
the two things. It can be an ossifying part of the cartilage of olecranon or the lateral condyle, I mean the trochlea. So
Yeah.
Gupta ji or Dr. Vishra Madhuri is there.
I'm just wondering whether it is like cutis calcinosis or something.
Yeah. So probably it's that. If we see these pictures now, her small hands, I'll just magnify the hand picture. This is her hands.
Okay.
So
Oh.
this is Gottron's rash, and probably the what we are seeing, the elbow ulcer, is calcinosis cutis. So this was a juvenile dermatomyositis child.
Okay.
So just a little bit of clinical examination into the skin and extra areas that tells us the diagnosis most of the time. Although this child, her CPK, LDH, everything is normal. So probably she just has a myopathic dermatomyositis. The rashes on the elbow also is Gottron's sign. If we see her knee, here also we can see the Gottron's sign is here. It is on the elbows. It is on the knuckles.
So in this disease, there is calcification on the kind of dorsal surface it happens of the joint, or
It
subcutaneous?
generally happens in the subcutaneous areas. When the inflammation, it is inflammation of the skin and the joints and the muscles. Luckily, this child doesn't have muscle involvement. She has skin and joints. So the skin, when it starts healing, it heals with calcification, and sometimes those calcific areas uh, lead to tissue ischemia or
Contracture.
cutaneous infarcts. It compromises the blood supply, the calcification, and that leads to cutaneous ulcers, and that can become secondary infected.
Right.
So, like this child initially was only polyarthritis, but little bit of examination helped us making a diagnosis. So, similarly, the list is very big. So, every case will be difficult. The other reasons which can present with good going polyarthritis could be IBD, ulcerative colitis, or Crohn's. They can have both the spine, neck pain, back pain, and rheumatoid like or polyarticular JIA like polyarthritis also. Sarcoid arthritis. There we can see this kind of boggy swelling in the joints. And if we do a synovial biopsy, that will show us granulomatous inflammatory arthritis. In pediatric population, especially the younger children, like less than 5 years, if we see this kind of boggy swelling and there is some bit of campylodactyly also, it could be, and there is uveitis. It could be sarcoid because of syndromic sarcoid, the Blau syndrome. It causes very young onset polyarthritis with uveitis. And sometimes it can cause lytic bone lesions also, which we may confuse with neoplastic diseases. Then the sterile osteomyelitis ones, they present with pain and swelling at one or two sides. Sometimes it is symmetrical. If we do MRI, we see the whole bone is inflamed, white color, and the child is unable to walk on that or unable to use that leg. And just NSAIDs, and 3 weeks after, if we repeat, everything is gone. The entire bone heals, and then the other site is involved. So many a times we don't find a genetic defect there, but it keeps on migrating. It is again treated like inflammatory arthritis if the episodes are recurrent.
Now, can I ask, for the case of calcinosis cutis,
Yes.
is there any specific treatment, or it's symptomatic treatment, or
For calcinosis cutis, it is treatment of the primary disease. We need to treat the primary disease aggressively so that the inflammation heals easily, and then it heals very fast so that the calcinosis doesn't develop. But it's like we cannot totally prevent it. Some drugs which show benefit in calcinosis is calcium channel blockers,
beta
uh,
block? Yeah.
calcium like diltiazem, or generally diltiazem is used, and nowadays tofacitinib seems to be helping in calcinosis cutis for like
Yeah, could I just ask you a doubt here? When
Yes.
we use diltiazem, it causes very severe hypotension or makes them feel unwell. Is that the experience, especially?
It can gradually, the doses can be gradually increased. Like we can, in children it will be more difficult because their blood pressure as such so we can start with a low dose and gradually build up, like every 2 months or 3 months doses can be built up. If it is gradually built up, they can tolerate. Even people who are normotensive, they can tolerate good doses of calcium channel blockers if it is introduced very slowly. Like we use a lot of vasodilator medicines in patients with systemic sclerosis whose baseline BP is 90/60. I'm talking about adult patients. So there we have to use a lot of vasodilators. We use calcium channel blockers and vasodilators for Raynaud's and digital ulcers and ischemic ulcers. There we give good doses of calcium channel blockers and PD4 inhibitors, and they are able to tolerate. But the crux is it has to be introduced very slowly, one by one, or increase the doses by 5-10 mg every month. So we generally start in summers also, so that by the time we reach winters, when it becomes worse, they are on a good dose of these drugs. Then like this kind of children who looks very sick, we can screen for immunodeficiency, especially if they are having recurrent infections. Many a times the immunodeficiency, especially the humoral ones, they present with arthritis where all the serologies are negative, because these children are not having immunoglobulin levels. IgG, IgA, IgM, everything is absent. So the auto antibodies may be absent also, or sometimes they can produce aberrant lot of antibodies also. So I think immunodeficiency should also be screened in children with polyarticular kind of presentation. Then others, like here also we have discussed a little bit the ones with systemic and other organ manifestations. So these kind of rashes, deformities, Raynaud's, the baseline reports, what I discussed, the blood count, kidney function, liver function, urine routine, and a chest x-ray. This will help us differentiate other like connective tissue disease, vasculitis spectrum. So all these connective tissue vasculitis can present with good going arthritis, but generally these children will be sick, and they are not referred as plain JIAs. They will have a lot of extra baggage along with the joints. So any extra baggage along with the joint, we should think of other diseases. I think the most common problem is the post-infectious arthritis rheumatic fever. I think now it's changing, but the dictum was few years ago, at least when I was doing MBBS, any child with joint pain, you do a ASO titer and start the child on penicillin, and that will continue for till he or she is 18. So actually that is not the norm. The rheumatic fever or post streptococcal reactive arthritis, this disease we really need to understand. It's a self-limiting disease, which even if not treated, it will heal and get okay by 8 to 12 weeks. This post acute rheumatic fever, the name is acute. So it doesn't, most of the acute symptoms like fever, joint pain, carditis, they get better in 3 to 4 weeks time, even if untreated. What stays beyond 6 to 8 weeks is chorea or subcutaneous nodules. Anyways, we are not focusing on them. And with the introduction of antibiotics and with the lot of availability and over-the-counter use of antibiotics, the incidence of rheumatic fever has significantly come down. Most of the sore throat, many a times, even parents give antibiotics to children. Otherwise also, even azithromycin is helpful in preventing, although augmentin will be better. So it's not that we should not suspect it, but the over suspicion in JIA in children with joint pain is not warranted, especially if a child who is coming with a complaint of joint pain of 4 months duration, we don't need to think acute rheumatic fever. The main symptoms of acute rheumatic fever is pain and swelling in large joints, generally hip, knee, ankle, wrist. It generally doesn't involve small joints. The child is very sick, will not be able to move, will not allow you to touch the joint. It's extremely painful. The pain is much out of proportion of joint swelling in acute rheumatic fever. There may be some erythematous skin rash. Child might be running fever. Fever could be around 100, 200, 300, 4 degree Fahrenheit. And maybe you may or may not find a heart murmur. The nodules in erythema marginatum, as such, they occur only in 2 to 5%, so hardly we see them. But the message I want to convey is JIA is the most common cause of arthritis in children. Acute rheumatic fever, we should suspect in 6 to 8 weeks or maximum like 8-10 weeks of thing, where we document a rising titer of ASO. It's the large joint, and it should not be thought as a differential diagnosis in children with 1 or 2 joints or who are having arthritis for long duration, 4, 5, 6 months. There, it's not a differential diagnosis. It should not be confused with JIA. And these children should not be given unnecessarily penicillin injections or tablets.
And again, they are kind of migratory.
Yes, migratory. Like it's like one joint will be involved for 4, 5 days. Then other joint will start getting involving by the time the previous one settles. Sometimes 2 or 3 can be involved together. It's not a fleeting kind of arthritis in rheumatic fever. It's a good arthritis.
We don't see this. I have not seen
Yeah,
this.
very few, very few. But still, I think in medical colleges, when I get
Because
referral from, still, I think the old time primary pediatricians, these children will be probably suspected by the, matlab they come with fever and joint pain. So still a big fraction still considers rheumatic fever as a,
Praful, should we stop doing ASO titers? See, JIA, I think, have joint pains with no fever or low grade fever. If there is high
yes.
grade fever, then you suspect something.
It could be systemic JIA or lupus or other causes.
Are you putting the both rheumatic fever and post-streptococcal reactive arthritis in the same
Right.
category?
No,
Because in my
reactive
experience, they're two
arthritis,
different entities.
they are two different, but I'm keeping them in this post-infectious arthritis group. At present, I was talking only about the acute rheumatic fever. Post-streptococcal reactive arthritis is a fleeting kind of arthritis which lasts for 4 to 6 weeks and get better. Only NSAIDs and supportive treatment is required. If you have confirmed it with rising titer of ASOs, a course of antibiotic should be given.
So we have had experience with this, and I've reported in Journal of Indian Medical Research also, one epidemic that we had long ago. But
Yes.
the post-streptococcal reactive arthritis can present exactly like a septic arthritis, except that you realize that you drained one, didn't find anything on culture, and then within few weeks or within few days, another joint comes up. And then you do the titers, and then we did the one which we reported had ASO, and they used to do one more titer called ADNB or something. I can't remember that.
Yes.
So in our case, it was an epidemic of ADNB thing, and we had like 13 cases within a radius of 50 kilometers. But we do see this off and on. It presents.
It will be the
and
acute kind
they
of
often get
presentation.
mistaken for septic arthritis because of the very acute presentation, and they get drained also. And
Yes.
then you find, because after some time you get another joint.
Yes.
That's how you actually have the suspicion. But that is definitely very much there. The post-streptococcal reactive arthritis, I've seen many times.
So post-streptococcal reactive arthritis generally presents with a polyarticular pattern, a fleeting kind of arthritis. The reactive arthritis, ma'am, you are talking about can occur after a sore throat, after urine infection, after diarrhea, where there is one joint, gross swelling. It presents like septic arthritis. Most cases they underwent surgery, a debridement also, and then the cultures come sterile. Then probably we come in the picture.
It's the same way. Post-streptococcal reactive arthritis can also be acute.
It can be acute, but generally it affects more than one joints.
Yeah, it does. They're not happening all at the same time. So you usually land up draining the one joint because you think it's septic before it goes on to the other joint. Then so you very often recognize it after you've already finished draining one joint.
So this kind of other reactive arthritis, which you were talking about, what ma'am is also describing, it can happen very rarely in post-streptococcal reactive arthritis also. But that spectrum is more with HLA-B27 associated ERA ones. Post-diarrhea, post-urine, post-urine infection, good going inflammation in knee or hip, and that generally presents like septic arthritis, underwent surgery in a week's time, and then all the cultures come sterile, and it is reactive arthritis. Then we dig into history, and sometimes there is history of spondyloarthritis in the family, or B27 comes positive. That is one presentation in ERA spectrum. Whether to exactly call it ERA, if like HLA-B27 is positive and family history of psoriasis or spondyloarthritis is there, we can label it. even the ERA variants, they can have a big flare after urine infection and diarrhea kind of infections, who are doing like totally good. And suddenly they'll come with multiple joint swelling after an episode of diarrhea. So
Okay.
other mimics, generally these would be easily, the history will be very much straightforward. Fever like chikungunya, acute onset polyarthritis where the child or the adult is just not able to move. Parvovirus, EBV will have specific kind of rashes. Typhoid, leptospira, brucella, they generally have fleeting kind of joint pain. Brucella can sometimes mimic ERA. It can also cause patchy inflammation in the spine and sacroiliac joint. So if you are seeing unilateral sacroiliitis and the history is very acute and the child looks sick, brucella can be excluded. Even TB and brucella. In unilateral sacroiliitis, we would like to exclude this. Then septic will generally TB. These are generally more evident and we'll do workup for them. So these won't be a routine mimic. Neoplastic, this is frequently missed. So when a child comes with joint pain and swelling, sometimes one or two joint or multiple joints, where they complain of night pains, there is more of periarticular swelling. Plain X-ray or MRI or scintigraphy shows mild elevation of the metaphysis. We should think of neoplastic conditions. The benign ones like osteoma generally presents with acute pain more during night time, where the child gets up at night because of pain. Pain lasts for a few hours and then it settles. So it presents with sometimes severe night pains which last for episodic and next day the child is playing. So there, if it is significant, maybe a MRI imaging or X-ray can show this. The other ones can be easily picked up. I just remember one case which was really very bad. A 14, 15-year-old boy with knee pain and swelling. He was being treated by a cardiologist as acute rheumatic fever. He was on penicillin prophylaxis for 2 years and he was like joint was little bit okay, but the swelling was still there. He came to us with development of diplopia. That time MRI brain was done which showed mets. Then we did his X-ray knee which was showing osteoid osteosarcoma. So actually it was osteoid osteosarcoma of the knee, which was it was osteosarcoma of the knee which was being treated as rheumatic fever. It was in UP during our residency time, but like 2 years it spread and it presented with CNS mets. So then hematological malignancies. So I think the red flags will be pain which is out of proportion of joint swelling, nocturnal pain, systemic symptoms, and always doing a blood count, kidney functions, liver functions helps. So here generally polyarticular arthritis, we would find the platelets to be on the higher side because platelets are also the acute phase reactants. So once ESR, CRP is rising, platelets also should be on the higher side. And the differential count. So differential count, if the lymphocytes are very high, there are red flags of pain out of proportion, nocturnal pain, child looking sick, pancytopenia, lymphocytosis, lymphadenopathy, hepatosplenomegaly. There we should consider hemat malignancy. Through 3 cases of oligo-JIA also I have come across, which was being treated as oligo-JIA. One though I think I was treating for oligo-JIA for 3 years. And this time the child was doing well. They presented after 1 year. They were taking treatment on their own. After 1 year, this time they presented. So the child was otherwise okay. I just asked them to do the routine test, which we ask on every visit. So the lab called up this time it is showing 85% blast. Just one knee was swollen. So doing a CBC at baseline always helps. In these joint disorders, especially in children, a baseline workup should be done in all children. Then the non-inflammatory conditions. There, this polyarticular or multiple joint pains, if we are not seeing platelets going hand in hand with ESR, CRP, there also think of neoplastic condition like leukemias, especially in young children. The non-inflammatory mimics this one can very closely mimic polyarticular or ERA spectrum of arthritis. So camptodactyly arthropathy coxavara's pericarditis syndrome. So here it's a rare inherited disorder because of mutation in proteoglycan 4 gene. It starts in infancy with camptodactyly of fifth finger, then good going arthritis starts, which involves small joints of hands, especially the PIP joints, wrist, knee, and hips, which develops in early childhood. The joints are swollen, but it's not painful. It is just looking at it, the joints are swollen. And later on, a good proportion of them develop femoral dysplasias, and they can be acetabular cysts, which leads to progressive Coxa-Vara deformities. Here, the inflammatory markers like ESR, CRP will always be normal. Even imaging, if we do, there can be good going synovial thickening and synovial proliferation, but the synovial biopsies won't show inflammation. It's just the proliferation. And some of them can also develop pericarditis and pericardial effusion to the tune of developing moderate to severe pericardial effusion, which requires a recurrent tapping also. So more likely to get, if they are developing pericardial effusions, more likely to get confused with those connective tissue disease kind of polyarthritis. Then another one, progressive pseudorheumatoid dysplasia. Here also, it's the loss of function mutation of WNT signaling pathway protein 3 gene. WNT1 pathway is involved. So in early childhood, they present with painless swelling of the PIP, MCP, wrist, knee joints. Later on, as the time goes on, they develop other features of epiphyseal dysplasias like abnormal posture, disproportionate short stature, kyphoscoliosis, hyperlordosis, and hip joint stiffness and deformities. And X-rays here will show classical epiphyseal and metaphyseal expansion. It's epiphyseal dysplasias. And sometimes the 2 or 3 children in the same family may be affected. So here again, the treatment is only supportive, but looking at it looks like polyarticular JIA, the kind of, especially 4, 5, 6, 7 years when the hip and the spine is not involved. Other skeletal dysplasias, they can present like classical JIA-like of deformities, but the inflammation won't be there. X-rays won't show erosion. It will show these kind of epiphyseal dysplasias. All the epiphyses are overgrown. And the spine X-rays can show platyspondyly. So another one is similar kind of PIP swellings, which develops in teenage years and is gradually progressive, but again, it's not painful. It's just visible joint swelling. There is absence of pain. There is no functional limitation. Acute phase reactants are normal. Serologies are normal. If we do local ultrasound, there is thickening of the epidermis and dermis, and biopsy from this dermal thickening sometimes shows fibroblast proliferation. So this is pachydermatodactyly, rare and benign. It's a rare disease, and it's a benign digital fibromatosis. Generally seen in people who do a lot of mechanical work or who play a lot of musical experiments. So sometimes it can happen because of repetitive trauma. No effective or definitive treatment is available. It is more common in males. starts in teenage years but can be seen in all age groups. So probably that repetitive work, that repeated trauma can be, if that can be decreased, that may help. But so that explains us the importance of doing the inflammatory markers and to document the inflammation before treating, because looking at these pictures, they also look like JIA. And many times when the arthritis polyarticular one develops in very small children, there they don't complain of pain that much, because probably they think that is the normal thing which they have been experiencing from the very childhood days. So other mimics could be storage disorders, chromosomal disorders. There the phenotypic features would guide us, and the hemoglobinopathies or thalassemias, they can cause, sickle cell can cause acute bone crisis and bone infarcts and intermittent arthritis. Then hemophilias, they can present with hemophilic arthritis. Others, rickets, fluorosis, they can also present with bone deformities. But I think last but not the least, these children with benign joint hypermobilities, they present with lot of aches and pains, always pain here, pain there. The activities are not restricted. You examine them, they will have this benign hypermobility score 8 by 7, 8 by 9, 7 by 9. They will have loose skin. Sometimes if they have trauma, they can develop these kind of very thin scars. So this group needs to be just reassured. As they grow up, the pains would decrease. They should, these other children who are likely to develop hip dislocation, shoulder dislocations. So it's a kind of manufacturing problem with their connective tissue, collagen. So just a reassurance is required there. So we may have missed out more mimics, but the crux is when we treat JIA, we need to control the inflammation completely, and to prevent, the aim is to prevent damage of joints and other extra-articular organs, and to target remission if possible. Early diagnosis and treatment, treatment and diagnosis is like much more urgency in pediatric age group as compared to adults. One more thing, they should never be advised any splints or rest. Inflamed joint should always be moved. Sometimes like village, the hardware or the local people, what they do is they apply a plaster cast around any inflamed joint. And in JIAs, if that stay for 6 to 8 weeks, that can lead to through and through bony ankylosis. I've seen 2-3 cases where knee joint was totally ankylosed and elbow joint was totally ankylosed. So there should be a big drive against those plaster casts. It should not be applied. Treatment options are many, similar as compared to the adults. These ones are more commonly used. In children, probably for the biologics, if 3 to 6 months they are not responding to DMARDs, we would advise, because they are growing skeleton, and we can avoid deformities if we treat them early. Regarding the vaccination in this group, live attenuated vaccine should be ideally given before starting the steroids or immunosuppressive therapies, or in the period where the children are in remission and we can hold those drugs for 2-3 weeks and then give live vaccines. The non-live vaccines, they are mostly safe, can be given, but that too also, when we are planning, it will be good to give the vaccines when the arthritis is well in control, because with the effect of these drugs, the vaccine uptake will be little less. Like a routine child, if vaccine immunogenicity is around 80 to 90% for a child on methotrexate and those kind of drugs, it will be around 60 to 70%. So as if possible, it can be modified in the vaccine period. So take-home message will be, it's the most common cause of chronic arthritis in childhood. It's the diagnosis of exclusion, and the most important part of diagnosis is to identify the mimics. So the pattern identification can help us. If it's predominantly arthritis, much more likely to be JIA. If it is arthritis with other skin, lungs, kidney, any other organ, and extra baggage with the joint, more likely to have a systemic disease. And non-inflammatory ones, there the baseline reports, the simple reports, it helps. And a good family history and like the duration of a health history always helps. Effective treatment modalities are there, and we need to be aggressive in treating arthritis in children. Long-term pregnancies generally is good if treated in time, but among all the variants, probably the ERA and RF positive polyarticular would have, they generally continue to have the same kind of arthritis in their adulthood, because ERA is the pediatric counterpart of ankylosing spondylitis, spondyloarthritis spectrum, and RF positive poly-JIA is the pediatric counterpart of rheumatoid arthritis. Others depend, like how they behave in the first initial years. Thank you.
Thank you so much, ma'am. I think at present we don't have any more questions. On behalf of OrthoKids, I'd like to thank you again for taking your time out and joining us. I think all of us had a lot of learning points, and we'll make the most of it in our practice. So
Could I just ask a doubt here, Dr.
Yes,
Vishwa
ma'am.
here?
Yes.
So you said you don't suggest that we do the immobilization, but when many patients present with deformities, so what do you suggest, traction, or how do you correct those deformities?
For deformities, a traction can be applied. Like when they sleep at night, that time tractions would help.
But they are sometimes they already have like 70, 80 degrees of deformity. So you don't suggest we do sort of wedge it out straight, or how do we correct that?
No. So if it can be corrected surgically, it can be done. Ma'am, what happens now? Like many of these children, they go to some local practitioners in their villages who just fix things. So there, what they do is they apply a plaster cast or splint, and they advise the children for a complete bed rest. I think there should be a protest against it. That should not be done. None of the doctors are doing it, but the alternative medicine and those kind of practitioners. Now, generally, these children from the city children, they come on time. The village children, they come after doing 3-4 months of something at their villages. There probably, if some kind of communication and we can outreach or tell the parents that it should not be done. Like even for these chronic conditions, they will come to us for once, twice, then something, then in like all chronic diseases, many a times they lost to follow up. They would come after 2 years. In between, they'll take some local treatment at the local place. So there, we should explain the children that keep the joints moving. The inflamed joint should be mobile. It should not be fixed in one position.
Okay, thank you.
Thank you, ma'am.
Okay, thank you once again, ma'am. And I will, ma'am, there was one last question: role of intra-articular steroids.
Intra-articular steroid is very good in oligoarticular JIA subgroup. Many a times, in fact, the first line treatment in oligoarticular is intra-articular steroid. So first intra-articular steroid, if it is better, we don't need to treat it further. If the pain and swelling recurs within 6 to 8 weeks of first intra-articular steroid, then probably we need to start the DMARDs. So it is first line, and even in other forms like a polyarticular JIA, if like child has just one inflamed joint and rest of all the joints are okay, instead of increasing the systemic treatment, we can just give one intra-articular in the one big inflamed joint, and rest are already doing good on the systemic treatment. Many a times the knee joint or hip joint, which are large joints, they take a lot of time to respond as compared to small joints like PIP, MCP, wrist. They respond early because the big joint probably has more synovial inflammation and more load to heal. So, and those are the ones which is restricting the child's mobility. So those big joints can be injected, but the intra-articular injection, the dictum is not more than 3 injections in a year, and the gap between 2 intra-articular injections should be at least 3 months. It will be good if it is 6 months. So not more than 3 injections in a year, no frequent then at 3-month intervals. And it will be good if we avoid too many intra-articular injections. But only one joint, go ahead. Probably that will be the best treatment, especially in oligoarticular ones who present with only one knee arthritis.
Okay, thank you, ma'am. I think our questions, there are no more new questions, so we'll conclude our session.
Okay.
Thank you so much, ma'am.
Thank you.